First, I would like to thank Dr. Srinivas sir, Dr. Pradeep sir for inviting us and arranging such a beautiful conference, BalanceCon 2018. Now, I will first start with a case. Patient present, 37 years male, presented with left otalgia and decreased hearing, history of exposure to cold, and after 2 days, he start giddiness, and the symptoms worsen in 7 days. Yeah. The video is ENG, VNG. Let's see the findings. Just note it. We'll discuss with experts and come to diagnosis. See these horizontal saccades.
Delegates want the history to be told again.
Patient, 37 years male, he presented with left otalgia and decreased hearing. History of 2 days there. History of exposure to cold. And after 2 days, patient developed giddiness and the symptoms worsens in 7 to 8 days. His VNG report is like this.
This was the first episode that the patient had.
No, he's only a spinning, only vertigo sensation, spinning sensation. Like, no, nothing. Then his vertical saccades.
Any other investigations done?
Here is to
we invite the audience actually. That is what what you deduce from this. If you need any more history, you provide that.
Means
do investigations are concerned, the audiometry was revealing sensory
neural loss.
Means do you think there is some abnormality in this?
Okay. In smooth pursuit.
Is this normal or abnormal? Just it is for discussion.
This one.
What exactly is the abnormality?
Yes.
Okay.
It is saccadic.
Saccadic pulse. Yes, sir. Yeah, कर दो. No.
रिपोर्ट में वीडियो
ना इसमें आ रहा है.
रिपोर्ट फाइल एक्सप्लोरर.
Yeah.
yes.
Yes. इसमें.
Folder में.
Okay.
वो reduce.
Okay.
Yes.
Saccades. Yes.
Pursuit is supposed to be a smooth movement of the eyes. What you see here is
Jerky movements.
that jerkiness is shown in the graph also. Rather than a smooth graph, you can see that the graph is step.
Okay. चलेगा.
फिर काट दे.
Optokinetics. This is right to left. Then top to bottom.
Is the,
Looks normal?
Yes, sir.
it is not possible.
This is bottom to top.
So there is okay. So there in vertical stimulation, you are seeing a significant horizontal component.
nystagmus.
Yeah.
Okay. Now nystagmus. In spontaneous light, we see when patient looks to right, he is having high amplitude and low frequency nystagmus initially, and when he looks to down to left, they have.
You can expand only that area, sir, nystagmus area, so that people can see better. Okay. Vertically expand, sir, so that. You want me to help?
Sir,
Yeah, I'll just expand.
yes. Sir.
So, any comments on the nystagmus from the audience? Right beating nystagmus, yeah.
Yeah.
Yeah, that also is okay. The projection is not good. Okay, that's okay. So that is also right beating nystagmus. Okay, right beating
Yes, sir.
nystagmus. You can play the video, sir, for them. Or you can
Yes,
go
sir.
spontaneous in dark. That shows much better.
Sir,
Spontaneous in
here
dark.
also so downbeating nystagmus.
Yeah, downbeating
in that.
nystagmus is there.
Specific downbeating nystagmus. Here. Here, sir. Is your pointer.
In spontaneous in dark, we can show them much better. Yeah, you can see a downbeating component.
Downbeating
Yeah. Spontaneous in dark.
Dark.
also.
Okay, okay.
Okay. Here.
Yeah.
Yeah.
बन्नी बताओ सर.
Right beating plus.
Difference from here and here.
Yeah.
Yeah.
On the left eye.
Yeah. Yeah.
Left eye.
It's a down.
Here is different, and then when the gaze is changed, this type of reaction is changed.
Right and left.
Okay. Did you notice that the sawtooth, the tips of the saw are pointing downwards on the upward part of the graph, and as they go to the other side, the sawtooth are pointing upwards, the tips of the sawtooth. So when the sawtooth tips are pointing downwards, it is right beating nystagmus. When it is the tips of the sawtooth are pointing upwards, this is left beating nystagmus, right? Yeah. So when the person is looking to the right beating nystagmus. When the person is looking to the left beating nystagmus. Okay, maybe we can play the video
Okay.
for people who can't read the graph.
क्या नहीं एक मिनट रिपोर्ट में.
Nystagmus spontaneous in dark. Yeah.
No, when patient is looked to right.
Let it play, sir. Let it play. So when the person looks to the right,
Right.
what is that? Can somebody tell? Can somebody tell? Is that a right beating nystagmus?
Yes.
Low amplitude or high amplitude in the beginning?
High.
High amplitude, low frequency in the beginning, right? When it comes to left?
Left.
It is left beating.
It's into left beating nystagmus.
Yeah.
With a low amplitude and a higher frequency.
Yes, sir. Low amplitude and high frequency.
Okay.
At this stage, can somebody think of what exactly this could be? First question, is it peripheral or is it central?
Okay. On looking gaze, when patient looks left, there is no nystagmus as such in gaze. But when patient looks to right, Here we see the nystagmus. Right beating nystagmus.
Yeah, and also a down. Yeah. Exactly.
Yes,
Exactly.
yes.
There is
This-
a small
this is the
pendular.
point.
Yeah, this is
Yes.
the point.
Yes.
Okay. There is the seesaw kind of pattern. In the vertical plane, there is a seesaw pattern here. You can see. Beautiful. Beautiful pickup. Yes, sir.
And in position test.
You can expand one area so that they can see the graph better, sir. Which beating? Yeah. Yeah, down beating and left beating. Yeah.
But it's a right disc Solpike.
Yeah.
And
In right disc sulpike, it is downbeat as well as left beating,
left beating.
downbeat and left beating.
Yes.
Something. And in right eye, it is again left beating and downbeat.
And when
And downbeat, yes.
So that means in both eyes it is downbeating nystagmus with a bit of left beating, that means towards the upper ear. Upper pole of the eye beating towards the left eye. Yes.
Do you notice anything else about the slow phase velocity pattern there? Just go back to that Dixalpic, right, sir? Yeah. Can you see anything abnormal or unusual about what you notice with the shape of this graph?
Not sharp.
Is it a straight line or is it more like this or like this? Okay. The slow phase is a curved slow phase. Yeah. So what does that indicate? A straight slow phase the straight slow phase is seen in peripheral disorders. Okay. In peripheral and hemispheric disorders. This is not that. Okay. The slow phase velocity has a little bit of a curve there. Okay.
on left side, left disc Solpike, the nystagmus is less.
Okay. Double click and show the entire graph. So what was downbeat there has become?
In vertical plane, it has become upbeat in
Upbeat,
the
yes.
right eye, and others it is unable to decipher, more like those square wave jerk. No. Vertical in left eye is downbeat. It is downbeat. Yes. And in what happens in horizontal leads? Can you explain that? It is happening quite commonly in some of my patients.
Okay. And the other possibility is that there are saccadic intrusions. Okay.
And head impulse is normal.
Yeah. Okay. You can see a mirror images of head movement and eye movement. So we can decipher that the head impulses have been good. Okay. So
What is the diagnosis?
what is the course of action that you would want to take?
I just want to inquire about the head impulse test. Normally, head impulse test given a heave like this, and it should not be immediately brought back. I think it has been brought back immediately. What should be the correct thing to do?
Yesterday we did the demonstration, so that will go on. Okay. Head impulse is something that even I am learning to perfect. Okay. Yes, sir. No problem.
So what's
So they are asking, what would you do in this patient next?
MRI?
it was normal, sir?
It was absolutely normal. Means in Every
This
aspect.
all symptoms comes in only 8 days.
Sensations.
Patient complaining all these complaints in 8 days only. 8.
That was normal.
It was
Tom.
deviation to the patient swayed a little bit to the left side. The patient swayed a little bit to the left side, but he was more worried about his pain, deafness, and what? Giddiness. Rather than his, he could, when he presented with, he walked with a little difficulty, but not much. He could move by also.
Is it possible that you could have thought of this as just vestibular neuronitis and wanted to, okay, if not for all these findings, is it possible that this patient could have gone home with a prescription for acute vestibular neuronitis? Yeah. 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 Now,
No.
what prompts you? Some of us told that, okay, he needs to go for an MRI. What is the decision? What is it that you saw till now which tells you that you should go for an MRI in this patient? Head impulse is normal. Perfect.
Head impulse is normal. There are so many direction changing nystagmus, that
Seesaw
pattern, seesaw pattern. Hearing loss, vertigo, progressive. Hearing loss and vertigo, that means together lesion has to be either in the labyrinth, it is not. Either in the eighth nerve, ruled out. I am speaking your language, sir, the way you taught me. Then the lesion, that means, but after their exit, they are different. So that means the only other lesion left is ICA or internal labyrinthine artery, logically speaking. So that means, and it is progressive. So that means, is it a thrombus type of thing and progressing thing, so which should be ruled out on MRI? That is.
So there is something else other than the ear. What else you saw abnormal findings? Normal head impulse test in acutely vertiginous patient is abnormal. Fine, that is what sir pointed out. What other, sir told about some more findings. What other abnormalities?
So, friends, what I want to draw your attention is that in a busy OPD, most of the time, Dr. Srinivas may be seeing this in detail, but we don't see this. And let me admit, we did not see the VNG in as much detail as we saw it yesterday. That was one. So giving VNG report in a flash is wrong. That is basic. It's not like an audiogram that you see for a while and give report. That's completely wrong. That's one message. Secondly, this was of a recent origin. It was not a long-standing one. So the first thing that could strike is a peripheral, because it was acute. This was not so. When we see this VNG in detail, we could make out that, okay, it was central. So next, of course, then you think of when we have ruled out everything else is MRI. We did MRI. There was a CP angle tumor. There was nothing like infarct. There was nothing like ICA. It was simple. So even a tumor can present in an acute way. That was what, you should not reach a conclusion just like that. The next best thing was that I sent the patient to the neurosurgeon. He said that it can be an acoustic neuroma, thinking that it was hearing loss and all these symptoms were. It was not so. It is the diagnosis. He has removed a tumor. HP examination is medulloblastoma in a 37-year-old. Yeah. Some things that is what I am reaching. I am inviting the audience that how you can explain each and every symptom in this patient.
This is an open forum, so we want.
It's not that we have reached. This is a conclusive diagnosis. There is no ambiguity about the same.
As far as the acute presentation of a vestibular schwannoma is concerned, the commonest reason is usually hemorrhage within the tumor. The tumor keeps growing slowly. and suddenly there is hemorrhagic change, which leads to a sudden expansion of the tumor, and then either the tumor is pressing on the cerebellum or the brainstem or the auditory nerve or the vestibular nerve, leading to an acute onset of any of the symptoms. Any of the symptoms. Pain is because of pressure on the vagal nerve. Lower cranial nerve, vagal nerve has innervation, outer external auditory canal, the middle ear. So if you have compression on the vagal nerve, you can definitely have vocal palsy, but at the same time, you can also have otalgia because of that.
The size of the tumor was 3.2 centimeters.
Since in a around even 3 centimeter tumor, the sudden loss of hearing is not a usual presentation for acoustic neuroma. Shouldn't we think also on these lines of vascular?
Sorry? See, a vascular event can always present as an acute incident, correct? Now, if the tumor is growing slowly, what happens is it splays the nerve. So the nerve is getting compromised very gradually, and therefore the function might not be affected. But then there is a sudden expansion of tumor. The nerve gets splayed suddenly. So beyond an axonatomesis, there is, beyond a neuropraxia, there is so much of stretching that it's a virtual axonatomesis. And that leads to the sudden onset of the hearing loss, right? I hope, that's a scientific explanation. Thank you.
So we recommend we should go back to the MRI, speak with the radiologist and find if there is a bleed. Or that MRI.
Sir, if you just give me time till 12 noon, I suppose a lot of your questions will get answered.
Wow. Okay. So sir is going to talk on radiology.
On radiology in balance disorder.
Yeah. Okay. What else in these findings prompted us to, if that one finding was there, probably I'll start thinking in terms of MRI. What was that? Some other finding which you saw, okay. Just based on this one finding, I find probably I'll think of an MRI. Okay. Was Brunn's nystagmus? Yeah, large amplitude on one direction, and the low amplitude on other direction. Did we see that here? Yes.
And my question is, in every downbeating nystagmus, we should do MRI or not?
This question, what is the audience opinion? See, downbeat nystagmus, yesterday also we had, Dr. Henry made a beautiful presentation of downbeat nystagmus, central causes. Then there was a time in the history of downbeat nystagmuses where all downbeat nystagmuses were anterior canal BPPV. Then because of that orientation, what happened? We started missing central causes. Then too many MRIs started coming normally. Then we now start thinking in terms of, again, anterior canal BPPV. Will we keep playing this ping pong ball between MRI, no MRI for downbeat nystagmus? Or is there some criteria which we can follow? Okay, downbeat nystagmus, we'll go for MRI if so-and-so happens. Comments?
I would first go for a Yakovino maneuver. And if the patient is all right after that and he becomes asymptomatic, I could probably leave it alone. But if not, then yes, MRI.
So, any other opinion? Yeah. No, he will do a Yakovino maneuver. If the patient is not relieved with Yakovino maneuver, then only he will go for MRI in a case of downbeat nystagmus. Yeah.
Good morning. So I believe in vestibular medicine, looking at only one symptom and deciding on an investigation is probably a fallacy. So if we just say downbeating, should we go or not? No, look at the entire picture. If the downbeating is with torsional component and you don't have central symptoms that could suggest central lesions, you may not probably need to go. It might be just the overactivity of anterior canal or the hypoactivity of posterior canal. Whichever way.
Okay. So we have two opinions here. Dr. Bijlani says that downbeat nystagmus, he will do a Yakovino. If he's not responding, he goes for MRI. Dr. Kshitij says he will, if the downbeat nystagmus is also associated with a torsional component, then he will not go for a MRI. Can we play that video?
This is other case.
Yeah.
So this is another case.
See, first thing is anterior canal BPPV is not very common. So is downbeat nystagmus not so common. Now anterior canal BPPV, as far as I remember from the literature, it may have a very minor torsional component, or the torsional component may be missing and it still might be anterior canal. So I think there's no harm in doing a Jacobino. And if the patient is fine. Yeah, I mean, overall picture, yes, I agree that you have to look at the overall picture. I agree with you. True, true. Over that point, I agree.
Yeah. Then one more thing, positional downbeat nystagmus versus spontaneous downbeat nystagmus. Spontaneous downbeat nystagmus, my belief is always MRI. What do you think?
I think we have to look at the bigger picture than confining ourselves to the audiovisual medicine. What I would do in this situation is at least get a neurology opinion. First, that covers you legally, and then you go for whatever you want to do. That is your personal thing. You don't get a neurology opinion and you later on somebody sees and they say, why the hell you didn't do MRI? I would just get a neurology opinion. From there, take it up.
In this patient, an MRI and a neurologist opinion was advised at the same time.
Yeah.
Patient got the MRI done, diagnosis was made, so sent to a neurosurgeon.
Great. And this patient received a very rapid diagnosis. Okay, what sir told? Protect our backs when things are not clear. It may look like an acute vestibular neuronitis, but then things are not clear. A little bit. What he saw a little bit of sway to one side. Just on the clinical, not by looking at the VNG, just based on the clinical criteria, he asked for a neurology opinion and an MRI. Okay.
MRI can be, you can have an MRI immediately, but you can't get a neurophysician opinion that easy.
In my talk, I'll be showing one case. A patient comes with sense of restlessness or vertigo, chakkar aata hai. And you examine him, no finding is there. The only finding is on doing perturbations, he tends to sway more on one side. On MRI, I have MRI pictures, everything, acute occipital infarct. So if it is not a proper, if it doesn't fit into standard, you must go for it. You must go.
And then if you ask for an MRI, what is the MRI that you're going to ask for? Because what happens, so many of these downbeat nystagmuses come back with a normal MRI. So when they come back with a normal MRI, is it that there is nothing in the MRI or we didn't do the correct MRI? What would you ask for, sir, in the MRI, in downbeat nystagmus? If you ask for what would you be asking for?
CV junction, cerebrovascular.
Okay. So, okay. Any other
Flocculus.
opinion? Dr. Sanket says he would want to ask for the craniovertebral junction, concentrate on the flocculus, concentrate
Flocculus.
okay. So on the nodulus, flocculus, this area. Then posterior circulation infarct, yes. Every person who of anterior canal BPPV, if he does not respond to Jacobino, does it mean that he does not have anterior canal BPPV? Sir, what is your opinion? No. Okay.
Go for MRI of
Inner ear, yes. Labyrinthine
Any
MRI.
particular reason or explanation for that? Yeah.
Again, don't take a downbeating nystagmus to be the gospel sign of a cerebellar problem. No, not necessary. You cannot even imagine the kind of pathologies we can actually land up with on an MRI, irrespective of, I mean, it's a classical posterior canal BPPV and still you can have a CP angle tumor. Intralabyrinthine vestibular schwannomas. Now, what will happen if there is an intralabyrinthine vestibular schwannoma which is actually involving the vestibule and the posterior semicircular canal? Wouldn't it lead to the same kind of a clinical presentation as a posterior canal BPPV? So please never ever make the mistake, of assuming that this is it and therefore I don't go any further beyond that. So cerebellum, the flocculonodular node, nodular part, the vermis, the Arnold-Chiari malformation, all said and done. you need to have an MRI concentrating on the inner ear A, on the internal auditory canal B, on the CP angle C, and it should be with gadolinium. Full stop. Every case, sir, every case. Do not leave the choice of the gadolinium on the radiologist. It's the gold standard. Open up the American Academy guidelines. The MRI for an inner ear, for a CP angle, inner ear, internal auditory canal pathology has to be with gadolinium, full stop. You will miss out on small vestibular schwannomas, very, very small vestibular schwannomas, 0.5 centimeter schwannomas, if you do not give GAD. Don't expect the T2 to be the virtual contrast for you. So please, please do remember, this is my opinion, that the MRI should be pre-contrast, post-contrast. You cannot leave it to chance. It's as simple as that. Look, put yourself in the patient's position. You are having what? Dizzy. You are dizzy. Simple. Irrespective of whether you've done the VNG, the SVV, irrespective of what you've done, all of them are the functional tests. Would you sleep peacefully if you know that one part is still remaining, and that's the structural aspect?
Your opinion on, suppose, like suspected case of vestibular paroxysmia, and will you like ask them to do this stuff in every case?
12 o'clock. There's a scan. There are the plates there.
Okay, so let us not take the...
Actually getting out my presentation.
Yeah. Okay, so we'll wait for 12 o'clock. We'll wait for 12 o'clock. Okay, I think they have one more video to show and to excite you, and then after that we go to the next talk. Yes, sir.
This is another case, just video presentation. This is right disc sulfide. Huh? This is pure or torsional or left, right?
It's a pure. Yes, sir. Downbeating.
Yeah. A little. First, what this has is, the finding here is there is a predominant downbeating component. In addition to that, there is this thing called this tie, okay, which goes this way. So one beat goes like this towards the right, another beat goes towards the left. But it is down. Can you see that? Notice that.
And the patient's complaint is vertigo since last 1 year.
One beat comes like this, one beat comes like this. It is like tracing an 8. Okay.
She is suffering from last 1 year. And other that every investigation is normal. Just only downbeating nystagmus. Nothing.
Now that every
MRI normal, MRI CV junction, everything is normal.
Yeah. I think now we have to take Dr. Manoj's opinion that what MRI was done may not be an adequate MRI, and we need to do a little more of MRI. So, sir, how many cases you have completed till now? Okay. No. Total cases in your clinical series?
I think 80 cases almost. 80 cases, 80, 90.
80, 90 cases. They must have got some 10 cases of downbeat?
Downbeat, yes, sir.
So, where were all these patients? Okay.
She's taking us
okay. Before we actually started looking at these patients as a core vestibular patients and evaluating them as vestibular, where were all these patients? So they are all there, every day they are coming. When we examine them, we get these findings. Okay. So thank you for that beautiful... Nothing.
She is taking Cineresin tablet and she feels fine with this tablet only.
That is the next thing. They have come here to ask. Now we have got some opinions. So probably that MRI was not adequate. I think they will go back after Manoj's lecture. They will do one more MRI. Okay.
I think it was not gadolinium.
Yeah. Okay. Okay. Thank you
Thank
so
you.
much for that exciting. Okay. I think they deserve a very, very big hand.